As a result of that, we said the only way we're going to fundamentally lower costs is to change behaviors and change outcome. We brought in practice management for the high-cost conditions. We brought in lifestyle changes, smoking, fitness centers. We're spending a lot of time now trying to reach into the family, which is hard because usually it's the whole family unit that sets the health, and usually the mom is the primary health thought leader in the home. So that's where we're headed. We've had great results. Actually, in just the first year of putting some of these efforts in place, we reduced hospitalization of our employees almost 12%. And that was a major intervention, and it primarily came through the big conditions that you would expect, the diabetes, CHF, and asthma. So again, I think this is the approach all of America will move to.
I'm delighted. I heard positive things from everybody, not as much gloom and doom as I would have expected. Maybe I should stop reading the papers. That might be the answer. We have some questions from the audience which I'd like to go through, and we were talking about 2015. Our first question pulls us back to 2011. A very practical issue, obviously reflects a lot of the concerns we have in this room. What options are available locally, underlined locally, to help small business keep costs down for insurance or make it more affordable? Anyone in the panel who has an insight?
Maybe an insurer should answer the question.
I was going to say,
well, obviously you should buy Humana. That's next question. But I'd like to have your input as well.
Well, I'll just say that to tag on to the employer comment, and I think that that's, a lot of who's in the audience. To control costs, you need to control the outcome. And, we're one of those employers that does everything that Tom said. You have the gym, you hold out the carrot in terms of smoke cessation, exercise, weight management, diabetes. You do all the things that you can to try and get your employees to be more cognizant of their health, the outcome of that health, and the costs associated with that. And from a, what do we do in Cincinnati? I think that there's a whole lot of avenues to try and raise the awareness of that and pull together and try and drive to some of those changes. The collaborative, the medical home models. At the end of the day, everybody's aiming for the same end goal. And so as small businesses try and deal with that, this seems to be a city that aggregates quite a bit and in times of need, those kinds of needs. And I think that there's certainly an opportunity to try and aggregate and provide programs or identify where they're available. There's a ton of not-for-profits trying to drive some of that health improvement that I think set up a model.
One of the biggest interventions we made, and it's a simple one, is to incentivize employees to do a health risk assessment and then do something with that data. And again, that's something everybody could do. You may not have in-house nurses or others, but you could incentivize people to get a physical. Part of the reason people are so in those extreme groups is, as Bob said, they never go to the doctor, they don't talk to them about their conditions, and unfortunately our physicians are too busy to proactively ask them about things that they're not coming in for saying, I need fixed. But when you get into a health risk assessment, all of a sudden people see, whoa, my lipids are up, my glucose level's not where it should be, my weight, my BMI is not where it should be, and here are the impacts. People start having those discussions. Not all of them will change, but some of them will.
One of the outcomes of that kind of health risk assessment, as Tom just described, though, with the hopefully early detection of some of those chronic conditions like diabetes, is that two things. One, you can direct that patient or that group of patients or individuals and employees into a direction where their diabetes can be managed through physicians, part of the network or not. In addition, there are financial incentives that can motivate those individuals to follow such a specific care plan to manage their diabetes more effectively, for example. So there's a financial reward that can be integrated into that to help funnel or direct employees that need that kind of specific care management in that direction.
And I'd like to add my own comment to that question as well, because I think that, as we've hopefully illustrated for the audience, there are an amazing variety of initiatives going on right here in our community. Again, you don't have to get on a plane and travel far away to tap into the expertise like we're seeing on our panel. Every one of our hospital systems in town is doing something along the lines that Tom is talking about. All the insurers are involved in that. Every insurer has a health risk assessment available. So I think probably the first thing that was positive that the questioner did was show up today to be able to pick the brains of the panel, and I would certainly encourage everyone in the audience to go online, to go to the websites of all the organizations represented here, realize that we have a lot of things available right here locally, frequently at zero cost to small employers that they can tap into and take advantage of it. And then I would say keep coming back to these kind of events, read the Cincy magazine, all the other publications that are focused on this. So a lot of learnings we can take advantage of right here. Next question deals with a topic that we all too often don't get around to in these kind of discussions, which is the issue of behavioral health, and specifically depression, but I would also include all the other aspects of behavioral health and the fact that there are many millions of people across the country and certainly many people in the Tri-State who are affected by that. And the question is, if we can lower costs by changing outcomes, what outcomes need to be focused on in order to affect behavioral health, and how can we integrate behavioral and medical health care?
I would just agree that it's one of the big issues, both nationally and locally. And I think it's one of those areas that, as you study it, it clearly has a dramatic impact. There's a lot of comorbidity from mental health, and we have not, as a society, really developed the right infrastructure to be able to care for people. There are many barriers to help people get the right amount of care and continued care. And also from just a medicine standpoint, we also don't have all the solutions to try to bring people into control. So it is without a doubt one of the areas. And it's one that we hope, and I know there's been efforts in the health reform bill to put some specific attention to behavior and mental health.
I think probably one of the things we need to do is reverse a trend of the last 20 or 30 years to separate physical and behavioral health in terms of focus. In a primary care, adult primary care practice, 50 to 60% of the patients will have a significant component of psychological, emotional illness with their physical illness. A lot of the insurance plans in the last 20 years have tried to get at this by carving out and saying, well, a family doc and internist really is not trained to that, so we'll carve out and we'll have behavioral health providers. And so what you do is you get a patient who has a combination of emotional and physical problems in themselves, being told to go to two different places to have that attended to. That doesn't work very well. And then one of the foci of the medical home is you bring that back together and you care for the whole patient rather than parts of the patient.
Yeah, and I would echo that, and that's a great observation. I think that's one of the reasons, again, without tooting our own horn, but we recognized when we did our data analysis that the overlap, for example, between diabetes and depression is huge, obesity and depression is huge, and that's why a number of years ago we actually brought our own behavioral health company internally to our company. So again, integrating that behavioral and medical piece of that is, I think, really important. Here's a question that goes back a little bit to what you were talking about earlier when we were talking about manpower. What can educators at the pre-K to 12 level do in their classrooms to help better prepare students for future health career needs?
Right. Well, we, as you would expect, put a lot of focus and energy behind providing opportunities for school systems to inform their students about the variety of health careers that are available to young people. When I talked about growth earlier, that's one of the elements I was referring to, is because the health system is changing so much and it's spreading more horizontally rather than vertically around a hospital, there are going to be so many more opportunities available. There are new jobs literally being created today that weren't around 3-5 years ago. So reaching into the school systems, Mercy Health Partners, having hospitals east, west, north, and central all around greater Cincinnati, are in a unique position to partner with any number of school systems, Fairfield, for example, Fairfield City Schools, Hamilton City Schools, that we have the opportunity to bring healthcare professionals into the classrooms and speak to students about the number and variety of health careers that would be available to them. Specifically in Fairfield City Schools, we have been working under a grant to work with all the fourth graders in all of the Fairfield City Schools around healthy behaviors, eating properly. We did that health risk assessment on all of those fourth grade students at the beginning of the school year, are putting an intense focus and working with the teachers at those schools around healthy behaviors, and we'll be reporting out those results. Just a small little pilot, but I think that one that has a lot of opportunity to grow and be spread to other school systems.
I'd say it's not just about careers, but it's about competencies. And I think the emphasis that we need to renew in American education is on the science competencies of kids coming out of high school and undergraduate degrees. You undoubtedly will have a whole nother breakfast later on in the year talking about the education system rather than just the healthcare system. And that is an area where we across the country are really struggling. This generation of high school graduates do not perform as well on standardized tests as the generation 20 years ago. And that is a direct problem of public education, and that needs to be addressed.
Here's a question that highlights something that I know every single person on the panel has dealt with, because you've all been involved in issues of changing physician behavior, technology. Physicians over 50, not that either of us are those, resist implementation of health IT and threaten to leave practice. How do you overcome this trend? The docs who say, I'm not using any of these doohickeys.
Well, it's, of course, you know, resistance to change is not generationally associated. You know, we kind of all are that way. But in my working with physician groups, there's no question that there are certain types and amounts of change that physicians at a given seniority are just going to say, you know, that's not for me. That's why I said 2015, 80% of the practices will be medical homes. Not everybody's going to do it. The interesting thing, though, is I think as Tom has talked about, more and more of these practices are now associated with systems. And more physicians practice with other physicians. So you may have your 55-year-old doc that says, I'm not going to do it, we're not going to do EHRs, but their partners are 35.
Electronic health records.
Electronic health records. But their partners are 35 and 43, and they say, we got to have it. So it becomes sort of a practice-by-practice cultural transformation. Not every practice will do it because the return on investment to a physician at a certain age to make a number of changes will just say, you know, I am going to retire at 63. That's not where the majority of the docs are that we're working with, and I don't see that as being a huge problem.
If I could just add into that, because we provide technology in all of our physician offices, we don't see that as a major problem. You do encounter it without a doubt, but by and large, one way or another, whether they go very willingly and happily or resent having to go there, but know they have to, for the most part, they do adopt the technology. The other component, you mentioned the younger physician in the practice, it's reliance on the total group dynamic within the practice, and so there are other members of that healthcare delivery system, their staff, their office manager. There's other people who they delegate to, that technical stuff that they may not want to do. So to your point about different careers and opportunities, there are different populations that you can tap into to drive the evolution of technology, not just the doc. And it does, to some degree, free them up to be the doc and do what they wanted to do all along.